Hello everyone and welcome to our Commonwealth Tribute to Life webinar series. It's an exciting webinar that we've got tonight with two very special speakers talking about consent legislation, which for many of us around the world is always quite a topic, whether we should be deemed consent or in other words, opt in or opt out. And tonight we've got myself, Lucinda Barry, the CEO of the Organ and Tissue Authority in Australia, who leads the national program for organ and tissue donation down south. And we've got Associate Professor Helen Opdam, who is our National Medical Director here in Australia, chairing the session. And it's exciting that we're going to be hearing from both the United Kingdom and Nova Scotia on their journey so far in a change of consent legislation. So it's quite a exciting and controversial topic, I think. So I think you're all going to have a very good experience, and we really look forward to hearing from our speakers. Just in the sense of being able to ask questions, there is a Q&A on Zoom, and if you'd like to pop questions into there or into the chat, the process will be we'll hear from our speakers first, and then we'll go to about 15 minutes of Q&A at the end. So thank you everyone from around the world for joining us. And I should say good morning to those who are in the Northern Hemisphere, and to my colleagues in Australia and New Zealand and other areas, good evening. And we'll kick off the webinar. So firstly, I'd like to welcome Claire Wilmont, who works for the NHSBT in the UK and is the executive who's accountable for implementing the opt-out legislation in the UK. She's been advising government on opt-out policy implications and was really making sure that they were ready for the change in their consent system there. And more recently, Claire's been working on maximising organ utilisation in the UK to make sure that transplant activity can keep pace with the anticipated increase in organ donation in the UK with the introduction of legislation. And Claire will talk us through about the process and what's been happening in the UK. So welcome, Claire, and we look forward to hearing from you.
Thank you very much, and thank you for inviting me to speak and share the UK experience. I shall just try and share my slides. If I go into present mode. Is that working?
That's great, Claire. We can see those slides, so okay. Thank you very much.
Great. Thank you. So I'm Claire Wilmont. I work for NHS Blood and Transplant. If I just give you a little bit of information about what we cover within NHS Blood and Transplant, or NHSBT. So everybody thinks about the four main countries, England, Scotland, Ireland, Wales, which we do cover, but there are actually 7 because we also cover Jersey, Guernsey and the Isle of Man. So you can see there the populations overall are just a little over 67 million, but they range from 57.8 million down to 0.1 million when you're talking about the small islands. And if you look at our religion, primarily Christian religion or no religion, but actually a fairly broad range and diversity of religions that we cover. And that's important for consent legislation that I'll come on to later. So if you look at our organ donation process so far in the UK, you see we've been at this for quite a while now. These figures only go back to 2000, but it actually predates that. And there's been 2 real game changers in organ donation journey so far. The first was the Organ Donation Task Force report, which was back in 2008. And that led to a real revolution in our organ donation journey. It engaged our intensive care teams. It provided us with the legal and the ethical and the clinical guidance that was required to support changes in organ donation. And it gave us things like central recruitment for our specialist nurses for organ donation. It established the National Organ Retrieval Service. So it provided us with that infrastructure, and that's led to our donor rates more or less doubling since that task force produced its report. In more recent years, we had our Taking Organ Transplantation to 2020 strategy, which was really trying to give a revolution in consent. So looking much more at that public awareness, still improving the organ utilisation, organ infrastructure for organ donation, and starting to look more at organ utilisation, but the focus was still very much on that public engagement. So those were quite game changers in the UK, and you can see that has led to increases in the donation rates. And if you look at starting to bring transplantation in and waiting list times, because that's what we're in it for at the end of the day, is organ donation so we can save lives through organ transplantation. You can see that there's been a 24% decrease in the waiting lists and near enough 50% increase in transplantation over that time. But I would just highlight, if you look at the 2017 through to 2019 data for the transplant waiting list, which is the green line, you can see it starting to creep up. This is even pre-COVID, so you can see things are starting to creep back up on the waiting list. And in terms of the organ donor register, which we have in the UK, it's opt-in and opt-out now for the organ donor register, and you can see the numbers going up and up. But part of the problem is that whilst consent rates have changed as well, they aren't keeping pace. So they're not keeping pace with the numbers of people that are signing on to the organ donor register. So whilst the last report tried to drive that change and revolution in consent, it's not quite pushed us over the line with where we were hoping to be. So in terms of UK legislation, at the moment there are still 3 countries within the UK and our associated territories that have opt-in as the legal basis. But Wales set the direction, set the tone, so they introduced opt-out back in 2015. So they've been going quite a while now. England followed in spring 2020, Scotland in spring 21, and Jersey in 2019 as well. But if I was giving this talk this time next year, I think that actually all of the countries will have opt-out as the legal basis for their consent for organ donation and tissue donation. So when I say opt-out across all of the jurisdictions, so there's all those different pieces of legislation, but they're all talking about the same type of opt-out, which is soft opt-out, which means the families will always be approached and their advice is always respected. We will take into account faith and beliefs. It's for deceased organ or tissue donation where that's a possibility. People have to be ordinarily resident in that country in order for opt-out to be applied. And the population is always encouraged to make their decision. The focus is very much, it's your decision, make your decision, we will respect that. And it shifts the focus to what the individual would have wanted rather than what the families want for those circumstances where opt-out applies. Where it doesn't apply is for children. The age of what you define as a child varies slightly between countries. Sometimes it's people over the age of 16, sometimes it's people who are aged 18 or over. It doesn't apply if there's a decision made on the organ donor register. So if somebody has ticked yes on the organ donor register and you don't apply opt-out, then that's a stated decision. It doesn't apply for people who lack mental capacity. For people who aren't living voluntarily in the country, so that means people like who are in the armed forces, for example, or prisoners who may have chosen to leave the country. It doesn't apply for anybody that's lived in the country for less than 12 months. And it also doesn't cover novel forms of donation. So for example, limb donation is not covered under opt-out, for that express consent from the families applies. And I'd just like to clarify that for all those categories with the X above it where it doesn't apply, that doesn't mean that organ donation isn't an option. It just means that we go for express consent from the families rather than applying opt-out legislation. So I'd like to talk to you a little bit about what the challenges were of bringing in opt-out legislation and the benefits that it brought with it. And there was quite a few. So if you look at the legislation process itself, it's not easy bringing in legislation. It was done very much in England by luck and chance rather than necessarily design, but we did get there. So the challenges it brings is you have to consult, you have to have a political will behind you in the first place to introduce it, and you have to consult, and that takes time and effort, and it requires debate and challenge across political parties, but it brings benefits with it. So in England, we have to, legally you're required to consult on any changes to legislation, and you would normally get, for a bill, you would normally get around 200 responses. Then they would see that as a very good level of response. For the introduction of opt-out legislation, they got over 17,000 responses, which was quite a shock to my colleagues in government, because they were not expecting that number. I don't think they put in quite as much free text as they did if they'd realised they were going to get that number. But it just shows it got the nation talking, and that's a benefit all by itself. Even if the legislation hadn't gone through, it got such engagement and debate going across the nation. And it also obviously caused debate and challenge across all the different political parties. And that gave us, again, real benefits. So there was great consensus across all of the political parties in England. And I must say it's been exactly the same in all the other countries that we've applied to opt-out as well. And as part of the benefit that that debate gives, it's the soft stuff that gets committed to during those debates, as well as just the legislation. So you'll see here Lord O'Shaughnessy, who was the health minister at the time, about making commitments. We will make sure that there are enough highly trained staff to make the most of the changes resulting from this bill. Baroness Mansour, again, a Lord's minister at the time, we will make sure the system is funded as it should be. And Jackie Doyle-Price, there will always be a personal discussion with the family at the bedside and special consideration about person's faith and the views of their loved ones. And those are public commitments that are recorded in Hansard that carry weight that ministers are expected to abide by. So that brings real benefits just through the legislation process, even if the legislation got nowhere. It obviously did, it obviously got through. In terms of introducing opt-out, you have to make sure that your operational teams are ready. You have to make sure that the specialist nurses, that the intensive care teams, that all the office teams that manage the processes around organ donation are ready. And that was a huge challenge. So we now have multiple organ donation laws in place across the UK that the teams must adhere to. And that brings challenges to them because some teams work across several different jurisdictions. And that we must have training. And we had to make changes to our IT, and we had to make changes to our national guidance and policies, and we had to have the resources to deliver the change. So you can see the picture down on the right-hand side there. That's me. I'm quite short in the middle, but with some of the team around me that was helping to deliver opt-out. At one point, I think there was about 120 of us that was delivering opt-out across about 80 different projects. And that's complex, that's difficult to do, but it delivers, again, huge benefits. So just within our organisation, it meant that we came together as a whole across many different areas of a very wide and disparate organisation, which was fantastic to do. But the fact that the legislation is slightly complex increases the likelihood of referral into NHSBT's highly trained team. So it supported that collaborative working with our hospitals around the UK. We consulted staff as the training was developed and as the law was progressing, which built on, brought in their engagement, made them more motivated, it improved their skills and their capabilities, it gave a refresh for what they were already doing. The changes to IT infrastructure has given us the opportunity to deliver additional improvements, and I'll come on to those shortly. In terms of the guidance and the policies, it's given improved reassurance and clarity, not just for our own staff, but also for the public and for our partners that we work very closely with, and people like faith and belief leaders is delivered improvements, and I'll come on to those. And like I mentioned, it brought us all together as a team and delivered ownership of the legislation that was great and reduced some of the silo working that we sometimes fall into. So I touched on faith and belief benefits there. So we introduced a faith and beliefs declaration into the organ donor register back in December 2018. So that's obviously before the change in law happened, but it was as a direct response to the consultation, to the change in legislation. So part of the benefit is, as a result of the consultation, it delivered benefits even for faith and belief communities, even before the law change happened. So we now have, as part of the organ donor register, a statement that says, I would like NHS staff to speak to my family and anyone else around me about how organ donation can go ahead in line with my faith and beliefs. Yes, it's applicable to me. No, it's not applicable to me, or you prefer not to say. People can just leave that blank. But it gives reassurance to people that organ donation will only proceed in line with their faith and beliefs. And it encouraged that debate and discussion. And as a result, we now have organ donor cards that are faith specific, which is fantastic. It gives people that reassurance. We have improved information on our website, and more importantly, although I've not shared any of those here, it's given improved information and reassurance on the community's website. So if you go onto the Board of Deputies of British Jews, for example, there's a whole range of information there. So it provided that collaboration and reassurance in a way that wasn't there before, and I don't think would have come about if the legislation hadn't taken place. I touched on IT earlier on, and again, as a direct result of commitments made as the legislation passed, is that integration with a new NHS app that has been in place since April 2019. And for the first time, people have we call it push and pull facility. So people can directly change their records on the organ donor register. They can see what their record is, and they can make amendments directly into the ODR as they see fit. And also, because it's part of the standard, if you register for the NHS app, it's one of the questions you're prompted. So we're now getting a lot of people recording their decision as a result of going on and registering to join the NHS app, which is fantastic. And we're leading the way for other health services as well that are now starting to link in with the NHS app. It's delivered also benefits in terms of public engagement. So I mentioned earlier on the 17,000 responses that we got to the legislation. The challenge was that there was public concern regarding the law change, a lot of concern about, well, that's the government taking ownership of you as soon as you die. They'll steal your organs as soon as you've died. And that confusion about what the law change meant. So as part of the benefits, we had focus groups to gain greater insight about what those concerns were. And then that led and steered our engagement activity and steered what the law said and provided some of those reassurances about sort of the myth busting, if you like. And again, the family will always have a role, the family will always be consulted. And it's also given us, as part of the benefit, the largest organ donation marketing campaign we've ever had in the history of NHSBT, I think in the history of the UK. It gives that impetus and that steer, and again, it gets people talking, it provides clarity in a way that hasn't been provided before. And I would add that our awareness around organ donation increased from 40% in the general population to 63% as a direct result of this activity. In terms of engagement, it's not enough just to have the public. Of course, it's important to have the public awareness campaigns, but you need more if you're introducing opt-out. So you need the clinical teams alongside you, you need the donation teams alongside you. And a lot of what I and my team on opt-out did is spend a lot of time engaging with the organ donation nurses, with hospital managers, with transplant teams, with hospital boards, with intensive care teams, and consulting them all the way along the legislation process. And I think that is important. We brought them in at the very start of the journey, and we carried on engaging with them all the way through so that they had a very strong voice. But that's not enough either. You need the infrastructure around government and ethics and regulators and the professional organisations and the Royal Colleges, who in the UK provide the training for teams. You need them to be aware of and engaged with the process, and they certainly did contribute to debates. And that's still not enough. You need the community leaders. I've touched on faith leaders, but actually the patient groups and the community leaders are very important here as well. And again, we spent a lot of time reaching out, engaging with people, providing them with material so that they could go on and continue and have those discussions within their own communities. And you need the media as well. And within the UK, we had very strong media support. And that brings benefits in terms of the improved collaboration. And I always say when I present about opt-out, if opt-out brings no other benefits, this collaboration is been absolutely key. We've had people speaking to each other that refused previously to even sit down in a room together. We've got the regulators, the faith communities, the NHS, the media, the ethics, the patient groups and Parliament all working together in a way that they have never done before. And that's continued. That support, that engagement is continuing to deliver benefits in wider organ donation work as we move forwards, but also within transplantation as we move forwards. And it's delivering benefits in transplantation as well. So one of the things that we're very keen to do is honour the gift of organ donation through improved utilisation. We've got the nation talking, we've got the nation supportive as a result of the introduction of opt-out, and we need to make sure that we do everything we can to maximise that. So there's now a new and renewed focus on making sure that transplantation services can keep up and can keep pace with the anticipated increase in organ donation. We've got a new organ utilisation programme established in NHSBT, and we've got a new organ utilisation group that's chaired by the NHS Medical Director, looking at how we can make changes to make sure that we support transplantation, we reduce any inequities in the system, and we support innovation. So in terms of the impact of introducing opt-out, I'm going to caveat myself by saying that in England, we went live in May 2020, which was at the very height of the first wave of the COVID pandemic. So any assessment that we can make has to be coloured by the fact that we've been implementing throughout the COVID pandemic. And that had a real impact on our marketing, our training, our awareness activity. And a lot of the opt-out teams, opt-out team members actually returned to the front line when COVID hit. So many of them were come from intensive care nurses. So our team took a huge hit just at the time when we were getting ready to go live, and so that made it challenging. One of my learnings was, trying not to go live in the middle of a worldwide pandemic. Maybe in the future, let's hope none of us have to face that again. But it makes assessing the impact of opt-out difficult. So I'm just putting that there as a caveat. But if you go back, so I'm going to take COVID out of the equation. And if you look back and you compare what's happened in Wales, you can see those two charts at the top there. So basically the dots are your statistical significance, and you'll see Wales, which at the time was opt-out, has a greater consent rate, or England at the bottom that at the time had opt-in as a legal basis, and you hit statistical significance for one system or the other when the dots hit. So you can see for DBD there that the dots hit the Welsh basis, the opt-out basis for consent, whereas for DCD it's less certain there, but you can see an upward trend towards the Welsh basis, which was opt-out as the legal basis for consent. And again, if you look at the changes in donor rates pre-COVID, you can see that that Wales, which had opt-out, the only one that had opt-out at the time, had the greatest increase. And at one point for DBD, their consent rate was 83%, which is, putting us up there amongst the big hitters, the world leaders like Spain for consent rates. So if you look at the impact, you can see there the organ donor registrations, and you can see the numbers of opt-outs starting to increase, which is exactly right and proper. What we're hoping is that people make their decision and record that decision. So we've now got a little over 40% of the UK population opted in. It's actually a little over 50% in Scotland. 3.1% of the UK population have opted out. It's 6.2% in Wales. We're expecting a higher proportion of opt-outs in England, and we're just not seeing that, whether that's because it's too soon to say, or whether because people can see what's happening in Wales and they've got that reassurance that it's actually a positive thing and it's not taking away people's decisions and people's choice. It's slightly too soon to say. We've got 78% awareness of the law change in England, and 39% awareness of organ donation in more general terms. At a peak, it was 46%. So we're seeing that impact in registrations and in awareness coming as a result of the change in legislation. In terms of the clinical impact, we've seen continued increase in referrals and that collaborative family approach, that real increased engagement at the hospital board to support resources for organ donation, and that continued improved infrastructure to support shared learning and best practice. And also, although I'll not put it on the slides, that continued commitment from government, from commissioners to support organ donation and transplantation proceeding wherever possible. In terms of the campaign impact, it drove an increase in awareness, and that's actually been sustained. Our awareness raising activity now has dropped away from organ donation, away from opt-out, to focus much more on making your decision. So our latest campaign was Leave Them Certain, which is, you know, leave your family certain about what you wanted to happen, because we'll still be speaking to them and they need to know. So that increase in awareness has continued. And I would just give a note of caution around consent rates for any other countries that are looking to introduce opt-out. They fluctuate wildly, often with no known cause whatsoever. So when we introduced in Wales, we were really concerned when we saw, you know, numbers going down, what was happening, what we were doing wrong. When they were going up, what was happening, what we were doing particularly right, and let's do that. But they do just fluctuate over time, and they're driven by a huge range of factors, such as marketing activity, media coverage, and so on. So in terms of outcome and where do we hope to be, these are our projections for donation and transplantation. So the government made a commitment for an additional 600 transplants as a result of opt-out. That was the English government. We actually think we can do better than that with our modelling. We actually think we can deliver significantly more than that. And at the end of the day, those additional transplants is what we want the donation for, so, and to honour that gift that people are making. So by up to the end of April, we'd seen 29% of all donors were on a deemed basis, so 640, which led to 1,540 transplants from deemed donors. So lessons learned. Engagement, I can't stress that enough. It took time, it took effort, but it delivered so many benefits and is absolutely crucial to people being aware of, and more importantly, accepting the change in legislation. And it led to some very difficult conversations, particularly with faith groups, but that actually strengthened, again, even if you take opt-out out of the equation, that strengthened it. But those conversations would never have been had if opt-out hadn't been introduced, because there was, before we'd either been banging on closed doors or didn't even know that there was a door to open in the first place. NHSBT took a key role in providing that advice and liaising with various different stakeholder groups. And I think that that was really helpful because we were impartial. We didn't write the law. We had to act within it. And using us as the conduit to having those discussions meant that they could be held openly and honestly and have those negotiations in a way that couldn't happen if it was the government helping those conversations. It increased our collaborative working. Another lesson learned was really look out for the fake news, which started to happen very early on, way before the legislation changed. And we closed some of those down, but actually because we'd had those discussions with the faith leaders and with the community leaders as part of the legislation discussion, actually they were willing to leap in alongside us and close those conversations down using peer-to-peer rather than us or government stepping in, which was very powerful. In terms of evaluation, the key metric really is consent rate, not donors. And you need to have that continuous evaluation over time. And it's not a quick win. Consent rates will fluctuate, and you need the transplant resources to keep pace. So in summary, legislation is only part of the answer. You need the infrastructure and support for change, but for us, it was part of the answer for supporting organ donation. And we're anticipating a lot of future benefits in terms of transplant numbers, consent rates, And I'd just like to thank my colleagues in NHSBT on the opt-out team, and most importantly, Max Johnson and Kira. So in England, it's Max and Kira's law in their honour. So Max received Kira Balls tragically died, and Max received her heart. Daniel Boyd, it's on the Isle of Man, it's Daniel's law, who tragically died and donated his organs, and Dahi is in desperate need of a heart transplant in Northern Ireland, and it's Dahi's law in Northern Ireland. So I'll stop there. I hope I haven't gone over time. I didn't set myself a timer.
Thank you so much, Claire. And I can see that questions are accumulating in the chat, but what we're going to do is go to our second speaker, and we'll hopefully have a lively discussion after we hear from Stephen Bede, who's going to be sharing the experience of introducing deemed consent in Nova Scotia, Canada. Stephen is a professor of anaesthesia and adult critical care at Dalhousie University at the QE2 Health Sciences Centre. Stephen served in leadership roles within the donation community for about 20 years, initially locally as the medical director of the provincial donation program, then nationally as a member and chair of the Deceased Donation Advisory Committee in Canada, and internationally as a counsellor and now the president of the International Society for Organ Donation and Procurement. Stephen's been the clinical lead for donation as Nova Scotia has implemented deemed consent. So I'll throw over to you, Stephen.
Well, thank you very much, Helen. And I'd like to get this going now with, can you see my screen?
Yes, that's great. Thank you.
Okay, great. Well, thank you for the introduction and for the opportunity to speak today. This recent opportunity in Nova Scotia is sort of the micro version of what you just heard about in the UK. But I'd like to walk you through our process, and maybe we'll have an interesting conversation at the end. But I see some themes in Nova Scotia that mirror very much what we heard from the UK. So what we hope to talk about is the Nova Scotia situation, how we saw this as an opportunity for change, what the actual act is, our change strategy. We want to talk a little bit about a research project that is going to answer some questions over time, hopefully, and lessons learned. So there's a lot to cover in a short period of time. Most people won't know anything about Nova Scotia. We're a very small province population-wise, but geographically, we're really challenged with the fact that Canada is huge. Our population density is small, and that's one of our challenges. So we're a small province in the far east of the country. We have one large academic medical center for adults, the same, another large academic medical center for pediatrics, and then a group of district referral hospitals. Our transplant program serves all 4 Atlantic provinces. So just to put that in perspective, we're covering a surface area of about 500,000 square kilometers. The entire UK is less than half of that. So we are faced with huge geographical challenges and low population density, and that does impact what we do and how we do it. But that's Nova Scotia. These are some representative pictures. It's a beautiful province. You're certainly welcome to visit anytime you want. I had to throw a picture in of winter because everybody thinks Canada is always winter. It's not, but we do get snow. So where are we coming from? This was a summary slide put together by Canadian Blood Services that looked at documented sort of system performance things that had worked around the world and whether they were in place in a variety of provinces. And I've highlighted a number of provinces where all of these key things were in place, to contrast it with Nova Scotia, because we were a very small province, but we didn't have everything in place that we'd like to. And that may have been reflected in our system performance. And yet, when you look at us, we've been like the little engine that could. If you look at the last decade or thereabouts, we had consistently had donation rates of more or less 20 donors per million, which is fairly respectable, given that we're a tiny program, and that was much, much better than the national donation rates. But what you see in that top right is that over a period of time, as a variety of provinces invested in infrastructure support to improve donation. Their rates were increasing, ours were staying flat. And in around 2017, after years of flat performance, we actually had a drop. And I was wondering if we were going to really get into more trouble. Would the government invest in system change, or was this our new reality? And at about that time, I got a phone call from this man who is the Premier of Nova Scotia. Premier McNeil really thought, as the Premier, that it just doesn't make sense to bury good organs. He didn't have a personal reason, except that it just didn't make sense to him that we were burying good organs, quote unquote. And so he began the process. And when the Premier phones you, you take the call, and the rest of the political machine falls in line when the Premier makes this a priority. And so we had some great conversations about how we could bring this in as part of system change. But the message I tried to get to him was that if we change the law, it's really just a bunch of words on a piece of paper. But if it's part of an opportunity to completely reboot our program, then we may have an opportunity for real success. And the argument was made that if you support donation, you're going to have to support the transplant program and the tissue bank as well, because our expected positive increase in donation would impact them as well. And we were able to successfully make that case. His party was all in, the opposition parties were not necessarily. So we met with them in a variety of committee meetings. And interestingly enough, this law was passed with money attached to it, with 100% approval. Now that is truly a rare event in the political world, but our political leaders got on board. It was the first time in North America this happened, so there was a lot of press coverage, and we wanted to make sure that we ended up with the right law, if you will. This was proclaimed in April of 2019, with plans to enact it in about a year, but it was delayed a little because of COVID. And we thought we needed time for planning, for infrastructure realignment, education, and so on. Little did we know how true that would turn out to be. And it's also worth pointing out that the new law focuses on deemed consent. That always gets the headline, but there were some other and very important things included in this law, including some clarity around the definition of death in the context of donation, the requirement for mandatory referral and reporting, so that we were now making our health zones accountable for performance, which hadn't happened before. And we put in there provision for family support, specifically connecting donor families to transplant recipients under the right circumstances. So the law was encompassing more than deemed consent. And deemed consent was somewhat akin to what we just heard. It was for adults, not for children. They had to have the capacity to consent. They had to actually be residents, so new immigrants, new arrivals, non-permanent residents of the province were not bound by this. And we knew that we had to support the right of people who disagreed. And so we did commit to developing an opt-out registry, and we committed to communication and inclusion of the family in the opt-out process. And so you can declare that you have opt-out by registering or by communicating with the family. And our intentional conversation was not to ask for consent from the family as much as it was to try and determine what the last expressed wish of the patient was. But that connection with family is absolutely crucial. Key partners, obviously Nova Scotia Health, including at the executive table, a VP was assigned to this, and critical care. Senior administration in the Department of Health and Wellness, including the Premier's office, and that moves the agenda. The communications department in the Department of Health. We also had partners with Nova Scotia Health Research and Innovation with the LEADER project, which I'll talk about in more detail. That was a very interesting collection of work. And of course, our transplant and tissue bank colleagues. Change management, we were trying to essentially reboot the entire program. It was like literally tear the paper up and start from the beginning and try and improve this. So we had to go through a lot of change. And essentially, we had to completely change the structure of the donation program. We were small, but we've increased the donor coordinator positions and changed their role. We established an education lead primarily focused on healthcare. We established the family liaison role to support donor families, but also for connection with recipients. We had to basically build from scratch a custom donor management platform that included a fairly robust potential donor audit tool. Historically, we were doing everything literally with paper, and that was a real problem, as we discovered. And we had to establish a donor physician network that was going to expand over 3 years. So the whole structure of the donation program was to change. And we had huge challenge with personnel. For a variety of reasons, we've turned over almost everybody. A new program manager, all 3 of our long-term coordinators were just due to retire. Their time came up, so we had to recruit and train brand new coordinators. We recruited a quality lead because our previous quality lead had been on long-term disability. Had to replace the admin lead, again, for retirement purposes. Established the family support liaison, the education lead, donation physicians, and an IT lead. So we had a huge number of personnel changes in and around this. The LEADER program is a funded research project through Health Canada in partnership with the people you see there, including Transplant Quebec, CDTRP, and Canadian Blood Services. The VP for research is Dr. Gail Tomlin Murphy, and she was the administrative lead, and I was one of the national co-leads with Dr. Matt Weiss, who some of you may know. And we committed to try to study this process. And we did it by focusing on, broadly speaking, 3 big areas. Activity 1 was defining the quantitative impact of the legislation. Activity 2 is understand the experience here and elsewhere, including ethics. And 3 was public and healthcare knowledge. And I'll expand on that a little bit. So activity 1 was really our attempt to take a good look at where we are so that we can really identify if this legislation has positively impacted us. If we didn't know where we were, we sure couldn't define a change. And so we have a variety of projects under the Activity 1 umbrella that have been focusing on where we were and what's been happening within the province as this legislation and system changes brought on board. And a variety of people are leading that. Activity 2 is focusing on general landscape internationally around deemed consent, as well as an ethical and legal review of deemed consent models with our province and other jurisdictions that use this model as our target under Activity 2. And Activity 3 is focusing on what do the public and the healthcare communities know, what's happening in the social media sphere as we brought this on board. And we tried to focus on attitudes and knowledge of our healthcare community, but also specifically focus on historically marginalized communities. We really wanted to understand what people knew at baseline and what they know as time goes forward. So this will be a bit of a longitudinal study. And we've also specifically been working with a colleague who has been looking at donor families as a broad project and now focus on our donor families in a deemed consent world. So a lot of work has happened under Activity 3 as well. And so far, there have been 5 manuscripts published. You can see some of them. There is another one that focuses on the social media response. And we have another 8 that are in progress with a variety of first authors that are at various stages of preparation. And we have another 9 that are in draft at least. And so when the dust settles on this, we're expecting between 20 and 30 publications or projects that help us to assess, what's happened here, and does that give us some of the answers on whether deemed consent is right. Now, we understand that we're a small program, and extrapolating from a small program to a much larger one is a bit of a stretch. but it's our attempt to develop both a model to study it, and maybe we will learn some valuable lessons. And I think we've learned a bunch already about the journey, if you will. One of them is if you're being honest with yourself, you really don't know what you don't know. And when we rebooted the program, we discovered that there were a lot of things that we thought we were doing well that we actually weren't. The healthcare teams really know much less about donation than you might assume they do. And so a conversation with the broader community needs to start with the basics of donation. The subtleties around the consent process are lost on you if you don't even know the basics around donation. And the presumption that our healthcare leaders across the province in nursing or medicine really understand this topic is a bit of a stretch. And we just need to factor that in. Communication has been an enormous challenge. And the conclusion that you sent information to a group means you communicated with them is clearly a problem. We found that a lot of people received information, but that didn't mean that we could claim to have communicated with them, in spite of the fact that there was an enormous amount of interest. A huge number of groups want to hear about this. It's also very interesting in some of our small group sessions that some of the groups that are historically labeled as anti-donation, for example, our African Canadian community, our Muslim community, when we actually talked to them, we discovered that they had questions around donation, but they were actually, generally speaking, very, very supportive of donation as long as certain rituals around death were respected. There were some knowledge gaps that required clarity, but their challenges with this were much more related to sort of systemic health problems. Our African Canadian community, for example, had some concerns around racial bias around healthcare in general, and that may have impacted a decision around donation. But it wasn't that they were anti-donation per se, it's that the healthcare system in general is a system that they have some challenges with. That was a very important lesson for us to learn. The messaging itself, this is one of the most important lessons I think I've learned, and that is that the public and the professionals, they want a healthcare message. They don't want a political or a legal one. And the people who need to control this messaging really should be the clinical. In our province, the communications group in the Department of Health took this on, and frankly, I think that was a major mistake in retrospect. The other important thing is in that messaging, the need for the family to feel like they still are going to be engaged came up over and over and over again. The idea that this law means that we're just going to take your organs, period, full stop, was a common concern, and families always said that they wanted to make sure they were still part of it. That came through loud and clear. The outcome, well, the metrics of success cannot be donor per million. There's a variety of other things that from a system point of view we need to look at. And as we started to honestly review where we were, we discovered that there were things, for example, our referral rates were much, much lower than we thought they were. I'm not sure that's a bad thing. That actually identifies the area that you can really focus your efforts in. And if they're bad to start with, then maybe that's an easy win. And so I think that the metrics of success really need to be extended way beyond donor per million, and consent rates are certainly a crucial one. The other take-home message, which we heard about already, is this is just not something that you can conclude based on a year or two. This is going to be an assessment that is many years in the making. The other thing about the opting out per se, what we anticipated was an avalanche of discontent. We didn't hear it. And what we, I think, may have been able to do was mute those people by very consciously, intentionally including the right of people to opt out, and that there was a process as an integral part of introducing the legislation. So all of those clusters that wanted to talk about how Big Brother was controlling their bodies were almost immediately muted by being told that if that's how you feel, we'll respect it. And it really diminished what we thought would be a large negative outcry. And perhaps because we've consciously reached out to historically marginally groups, we saw less resistance than we may have anticipated. The other thing that we have discovered is that the percent of people opting out, which now has gone up to about 5.1%. We were starting with about 3%, but over the last year and a half, it's increased to about 5.1%. A huge number of them, as we've discovered, are opting out for the probably wrong reasons, if you will. A lot of them are concluding they should just opt out because they wouldn't be medically suitable, as opposed to, I do not want this because I want personal autonomy or whatever. So those are some very important lessons learned. And I want to thank, these are the key senior leaders that have helped with this project, but many, many more people have been involved. And I'll stop there. And you'll note I intentionally did not tell you about what's happened with the results yet, because as I said, it's very early, but I'm happy to have a conversation.
Thanks so much, Stephen. That was a fabulous summary. And I'm going to lead off with a question to both of you, and I'll try to incorporate a question from the chat as well. And I think what came through very strongly with both of your talks is that it's much more complicated than a simple legislative change. It's all of the government and stakeholder support, it's the resourcing, it's the associated sort of initiatives that one undertakes through the process of introducing opt-out and sort of the engagement with the various groups. So a two-part question, what would your advice be, because you know a lot of countries are looking at this, what would your advice be if there was government desire to shift to opt-out, but not necessarily the resourcing being offered behind it? You know, people were wedded to, this is a quick solution, let's do the legislative change. And a second part of the question, this comes from the chat, those countries, and many of us have sort of, you know, soft opt-in, what about the opposite approach and moving to a hard opt-in, which is what really the US has, so that when people are registered, family cannot overturn that decision. So I'll throw to Claire first.
Thanks. So to answer your first one about what if there's the government desire but not the government commitment for the resources that go with it, that's exactly what the situation we were in England, and I think it's fair to say probably the other countries as well. They thought it would be a really quick and simple thing to introduce. They found out that it wasn't a really quick and simple thing to do, but by that point they committed to doing it anyway. So actually the resources had to follow, and it puts you in a better position because in the way that it works in the UK, I don't know about elsewhere in the world, and if something is as a result of a law change, they have to resource it. You will go to the top of the list when it comes to allocating funding. So again, it worked beautifully in our favour that they thought it would be really quick and simple, and in fact it was far more complicated than they anticipated, and they had to put their money where their mouth was, and they did. To be fair, all of the UK countries did indeed put their money where their mouth was. So I wouldn't see that as a barrier. I would see that as a positive. Let them be as naive as they want. And in terms of, do you bring in a hard opt-in before you then consider moving to a hard opt-out? Not hard opt-out, to a soft opt-out. Introducing legislative change is difficult, and you're not going to get many attempts at it. I think you'll only get one attempt per lifetime, I think, with this. So you need to gauge where your political decisions are, where your political will is, and more important, you need to gauge where your clinical and public will is, and respond to that appropriately. So across the UK, there was really, really, really overwhelming strong support for the introduction of opt-out. There were media campaigns for it, and there was a political will. So you need those, but you need to gauge what the appetite of your country is, and that's in the wider sense.
I guess my response would be somewhat similar. if you're just going to get a law without support, don't bother. It's a complete and utter waste of time. If the law mandates that the support follows, then so be it. Or if the negotiation you make before the law gets signed is that support has to come, then you may very well be in a good spot. But if it's strictly a law, and we've had several provinces in Canada, for example, have private members sponsor a bill like this, so it becomes a law in the sense that the private member did get it passed, but because it's a private member's bill, money and support is not attached to it, nothing's going to happen. It's in my opinion, it's irrelevant to have a law unless you've resourced what's needed to make the law potentially successful through whatever that mechanism is. And as for the other question about hard opt-in, the funny thing is the vast majority of people, whether they're lay public or they're the politicians, think that when you've said you want to donate, that it is hard opt-in. And the idea that families could refuse consent is a big surprise to most people. Now, when we've encountered families that refuse to provide consent when somebody had registered, we typically defer to the family. Maybe we shouldn't, and if we were in the States, we wouldn't. We would just be going ahead. So that hard opt-in thing, I don't know that it would be viewed by the broader medical community positively. Very committed donation advocates might understand the subtleties, if you will. Most of our medical colleagues and the public at large might view us as being, extra hard on families in the middle of a crisis. It's a confusing issue. I do agree that a real change, real system change probably is going to come along once in a lifetime. You don't get to do a reboot every 5 years. No way.
I would just add to that, out of interest, in England, it was actually a private member's bill. It wasn't a government one. It's just that the government backed it and supported it. So it's an interesting, we at a time when all of the UK governments were stabbing each other in the back, and indeed themselves in the back, with all sorts of leadership challenges and so on. It was the one thing that they all came together and supported. So you got all the very opposing parties. It became embarrassing, a bit of a loving in the debates, all wanting this to go through.
Claire, there was one other comment to you in the chat with a question, but the comment's really that it's great to see the collaboration across groups and parliament, ethics and faith, etc. But the question was, to what extent is there collaboration across the 4 countries in the UK that are in the process now and have opt-out?
There's complete collaboration. So we work very, very closely with all of the different governments, and indeed each of them set their own legislation. There is slight differences. That's to reflect their own populations and their own individual laws. But for example, Wales went first. England made some slight changes to a different approach to the way that Wales introduced theirs. So now Wales is going back and changing their secondary legislation so it marries up with what's in place in England and Scotland and what will be in place in Northern Ireland. So there's very, very good collaborative working across the UK governments, and obviously NHSBT works across all 4, well, all 7 if you add in the islands.
Fabulous for that. And I just had one question to both of you as well. If there was, I'll start with you, Stephen, at the moment. If there was one thing that you would change about the process so far, is there something that you would change?
It's very easy to me. I think I would have completely revamped the communication strategy that was put in place and insisted that the clinicians sort of control the messaging, work with communication specialists because they know how to sort of frame it and they know the right targets and all that. But the messaging and the way that we are connecting with the communities at large is a golden opportunity to be successful or a major opportunity to fail. you know, it's a really important part of success. And if you don't have a really good communication strategy that I think is clinically based, you're way behind the 8 ball. And that's one of our challenges. For example, the lawyers sort of say, well, it's the law. Of course, you know, the law is the law. Well, he signed his consent, just do it. And every clinician knows that if you're standing at the bedside with a grieving family, that's just not the way the world works most of the time. And that's kind of the point I would make. So the whole communication strategy has got to be done the right way and clinically driven, even if the communication specialists help you identify the right, you know, vehicle or whatever.
Fabulous comment, Stephen, and I'm sure that everybody on the line would be able to relate to that and the importance of what actually happens on the ground. And Claire?
So I would have preferred to not go live in England at the height of the COVID pandemic. Would have been really nice. That caused many sleepless nights, but you know, we were where we were. I suppose something that I would have done differently, I didn't fight hard enough, I don't think, for the transplant resources as well to back it up, because there's no point having donation if the transplant community can't keep pace. I think I would have fought harder to say, yes, of course you need to introduce opt-out and you need the resources to back that, but you need the resources to back transplantation to make sure that that very precious gift is honoured in every single way. And is so I think I would have fought harder, and I think that I may have missed a trick in not doing that. We still have got support, but I think I could have done better if I had my time over.
Great, thanks, Claire.
I might make a brief comment,
yeah.
and a tiny bit of data. I would include tissue in that as well. We've had a 40% increase in tissue donation. Well, if you hadn't anticipated that, and all of a sudden you're getting a ton of phone calls about a tissue donor that you have to say no to, then you know, you're in trouble. So when we talk about this, supporting the transplant is crucial, but so is tissue in our jurisdiction.
I would agree, and for yeah, I was meaning that in the widest sense, yeah.
Fabulous, and I think we're probably at the end of the webinar time. Thank you for everyone who's joined in. Thank you to Helen, the co-chair, but an important thanks to Claire and Stephen for sharing your journeys so far, and I'm sure that it will be one of the most watched recorded webinars. I know that many people, particularly here in Australia, would are looking forward to watching it. It's quite late night here for us at the moment, but thank you very much for your time and for being a part of the Tribute to Life webinars. For those on the line, we have a next webinar will be on Wednesday, the 15th of June, and the title is A Two-Nation Focus, the National Organ Donation and Transplantation System in Singapore and Sri Lanka. And that's at 12 o'clock UK time, but we'll be sending out more information on that webinar ahead of time. But thank you everyone who's joined in tonight, and thank you especially to Claire and Stephen for sharing your experiences.
Thank you for having us.
Thank you.
Thank you.
Thanks, everyone.